Hi everybody, welcome back to another edition of ECG Insights. My name is Alex and I'm back here again with Dr. Kalgi. Thank you for joining us once again.
Thank you so much for having me here again, Alex.
All right.
Love being here.
Yeah, if you're not familiar with Dr. Kalgi, he is a consultant here at Mayo Clinic as an electrophysiologist with Heart Rhythm Services. He specializes in cardiac invasive therapies and electrophysiology for catheter ablations and for atrial and ventricular arrhythmias. His research focuses on cardioneural ablations for novel energy resources and includes electroporation, radio ablations, and using proton and photon beam therapy. His research also is to help better understand the mechanisms of cardiac arrhythmias and procedural innovation, and also is involved with AI ECG here in electrophysiology in regarding cardiomyopathy patients with frequent PVCs. So welcome for joining back with us here today.
Thank you again for having me.
Absolutely. So once again, our learning objectives for these sessions have to do with identifying key ECG features, applying basic and even advanced interpretation skills for common arrhythmias and conduction abnormalities, and as well as relating that to allied health roles and explaining their clinical significance a little bit more in detail. All right, so let's dive right into our first ECG example.
Let's do it. So, and in our previous sessions, I spent a minute early on saying that when you look at an ECG, I want someone at all levels, first-time reader, or this your 100,000th ECG, doesn't matter. The approach should stay similar, and then each time you come back to an ECG, you'll see that you understand more and more layers of it. And for beginners, everyone should understand the golden rule of ECGs, and I always start with this because it's the most important rule, is if you know where the leads are placed on the chest, then you can figure out what's happening in the ECG. So, for example, lead 1 goes from the right arm to the left arm. Lead 2 goes from the right arm to the leg. Lead 3 goes from the left arm to the leg. And then we have these augmented leads, ABR, ABL, and ABF, which go to the right arm, left arm, and the foot, respectively. And then we have a set of precordial leads, so starting in the right fourth intercostal space, all the way across the chest to the apex of the heart, which is V6, and the heart is usually a little more leftward than what I've drawn here. So when we understand this, any activity going towards a lead will be a positive deflection, and any activity going away from the lead would be a negative deflection. And some of you who've seen our prior sessions can think in their head, if you have a sinus P wave that begins here, we know that activity is going in the direction of lead 1. So lead 1 has to be positive. And then here, although it's a little flat, it is a positive P wave in lead 1. Also, a sinus P wave is going down to from the top of the atrium to the bottom. So your lead 2, 3 AVF should be positive. Okay. And the only lead where it's going against or going away from is ABR. So it's going in the opposite direction. So when you look at ABR, that's a negative P wave. That's all you need to call a rhythm sinus rhythm. And similarly, we can apply this to other ECGs or QRS complexes as we see them, and we'll get to that. But then now sort of going into some of the more important details of this ECG tracing. So you start out with a sinus beat, then the PR intervals is a little long. So anything more than 200 milliseconds would be a first degree AV block. It's sort of getting there. Gets a little longer maybe on the second beat. And then you have a drop. And when you have multiple leads here, and then you're looking at a longitudinal version of what's happening, it's important to look at the rhythm strips. And every ECG will be different. Here, Alex has been kind to us. He's given us 3 rhythm strips to look at. So if you look at all of these, you have P QRS, P, a little longer QRS, P, and a drop. And if, from those of you who were there in the previous session, a successive PR prolongation and a drop followed by a short PR interval is Mobitz 1 AB block. Second degree AB blocks are those where some of the P waves are conducted and others are not conducted. And this is a kind of second degree heart block, which is at the level of the AV node, and it's a Mobitz 1 or Benke-Buck AV block. And then we see that again, PR prolongation, 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 a little longer, and then drop. And the next one will be a little shorter. So nice example of that. On average, the rate ends up being 46. The computer is good at some things, it's not so good at some other things. It's pretty good at the rate. And if you want to practice this yourself, you can count the number of QRSs in the rhythm strip. So there's 1, 2, 3, 4, 5, 6, 7, and then there's probably one that's right there or close to it. You multiply that by 6. And why do we do that? Because this is a 10-second strip. So if you multiply that by 6, it'll be 42 in this case, and that'll be close to the rate for the patient. And the other method you all might have heard is counting the boxes, and then is 300 divided by the number of big boxes. The problem with that method here is this is an irregular ECG. And if you take these two QRSs, the rate's very different than these two QRSs. And we care about an average escape rate. So something like that rhythm strip method will work well for this. But if we have a regular ECG and you see something like this, where you have half, 1, 2, 3, 4, 5, and another half, that's like 6 big boxes. 300 divided by 6 is 50. So if the rate was like this the whole time, then the average rate would be 50 beats a minute. But in this case, it's a little slower because some of these RR complexes, RR intervals are longer.
Absolutely. And when you're talking about like most textbook Winky box, you just kind of outlined a lot of the main characteristics, but that's kind of in textbook world. What I'm hoping to try to dive into a little bit here is non-textbook world, where your P2Ps don't perfectly march out, or your measurements don't march out as clearly as they should.
Yeah.
So that's what we're going to be diving into here a little bit next.
Yeah, let's do it. So we can go to the next tracing that you have and talk about it there.
All right.
So go on.
Nope. So we have 3 different tracings here. So once again, this is based off of one of our reports. So we have that what appears to be that Winky-Bach pattern here in our first example here. We also once again have a Winky-Bach pattern again here in B. It results in a pause, 3.3 second pause, but we have something that looks like AFib, potentially atrial flutter. And then same thing here in A, B, and C. So let's start with A and kind of talk about why this ECG example for Winky-Bach is not your textbook example.
Yeah, so great point, and you should give us a little clue here. So when you look at P2P intervals in a classic Winky-Bach, it should be normal because the level of the block is the AB node, right? So why is the sinus node getting affected? So when we see something different, so if we see, and if you put a caliper, it'll be a little more obvious. If your P2P starts lengthening from beat to beat, and you have the AB block at the same time, this goes to the point that 2 separate parts of the heart should not strike out at the same time. There's something else going on outside the heart. And the most common condition there is the vagus nerve being overactive, or a high vagal tone, hypervagotonia. You'll hear different terms for the same condition, but a high vagal tone can slow down the sinus node as well as the AB node. There are some examples that will be more obvious, like something like this, where you can clearly see P2P lengthening, right? So when you see something like that, where you don't have to put calipers, you can see it with naked eyes, that is a high vagal tone causing this. And the management is a little different. So again, this was Mobitz 1 to begin with, but even if this is complete heart block and a vagal tone causing this, there are some other treatment modalities available for that. And this would be new for many of the people in the audience. And we have something called cardioneural ablation now. So back in the day when people had long AV blocks or complete heart block, syncope episodes with vasovagal syndrome, we try some conservative measures, try some fluid, salt supplementation, try some compression garments. The only class 1 recommendation is educating them that the diagnosis is benign. But good luck telling that to someone who fell down and had a brain bleed. I've had patients working in factories where one syncope episode is too many. They're working with heavy machinery. Others that are, they have a newborn and they're carrying the newborn when they had their first syncopal episode.
Absolutely.
Not fun. So for those patients, and there are special scenarios where they tried conservative measures but still passing out. For these patients, the guidelines recommended putting in a pacemaker, especially if they're more than 40 years of age. But now we have this modality where we can put catheters inside the heart, not too dissimilar from the way we perform AFib ablation, but we target the nerve cells as opposed to the muscle cells. And we perform a vagal denervation, speed up their heart rate, speed up the AB node and sinus node, and prevent a pacemaker. So very promising treatment option for a lot of these patients. We've been able to avoid pacemakers in over 60 patients at this point, and excited to keep moving that field forward.
That's incredible.
That's kind of what we're seeing on this tracing.
Absolutely. So then moving into the next one, just provides a little bit more detail of pretty much everything that we had talked about, maybe it's a little bit more clear measurements here based on the drawings, but just you see the progressive lengthening of the P2P measurement, also the PR. which we get a lot of questions from like an education standpoint. Well, my P2Ps aren't marching out perfectly. Is there any need for like the technicians to point that out, or it's just you call it Wenke-Bach and we just provide our interpretation and you guys take it from there?
Yeah, I think calling it Wenke-Bach is sufficient because sometimes it can be confusing because we can have sinus arrhythmia as well, where you can have to 10 to 15% of variation in the sinus beat even normally. So if you see some are faster, some are shorter, that won't quite fit the picture. But if you see something like that example where there's clear P2P prolongation between tracings and you see PR prolongation or AB block, I think adding something like, query-vagal mechanism is great because not many people think about it, believe it or not. And this is something you guys are seeing all the time. And once you do 10 of these, it'll become second nature to find these when they're happening. And that can be the difference between someone getting a pacemaker versus not, because some of these happen in the middle of the night and people get sent to the emergency room. There's a trigger response. They get scheduled for a pacemaker the next day and they get a pacemaker, come back for follow-up, 0% pacing. They never needed the pacemaker to begin with. And now they're living with the pacemaker for the rest of their life. So your extra 30 seconds there could make a world of difference in some of these patients. So if you see something like that, and you don't have to say this is absolutely that, because no one knows, but you can say, mention the observation that there's P2P prolongation along with the AV block, then the people can start thinking about it. And that brings me back to a general skill of ECG reading is a lot of us are pressured when we look at ECGs that we have to get the diagnosis right. If someone asks us, we have to know what exactly this patient has. But the truth is many of us don't know to be sure until we get the patient to the EP lab. So it's important to make observations. And then the more observations you make, you start linking them to diagnoses later. That linking to diagnosis is actually less important. Making the observation is more important. So saying something like the P waves are upright in 2-3 AVF, when you're reading an ECG, maybe sinus, could be something else. QRS looks normal transition across the precordium, likely normal QRS. P2P prolongation, AV block, question vagal, and then that's a very helpful addition to an ECG reading. I know you guys are very busy, but if there's something that people can do, I think it'll make a big difference in some of the patients.
Absolutely. So then this is just another example, different patient. And so it might be a little bit hard for those where you're trying to look a little bit closer. But this is just another example where you have Wenke-Bach, and you also have Wenke-Bach down here below, but you're also having somewhat appear to be non-conducted PACs as well.
Yeah, and then this is often misdiagnosed as Mobitz 2 AV block because what we need to do to diagnose a non-conducted PAC is you want to look at the P wave morphology. Going back to our original Einthoven's triangle diagram, so we have lead 2 and lead 1, right? They're positive in both of them, so likely sinus. But this P wave here is a little shorter, is a little narrower than this P wave here, okay? And same with this. So it is coming from a lower part of the right atrium, assuming this is a sinus node as well. And it's got a narrower width. That means it's coming from closer to the conduction system, which is on the septum. So we know it's not quite where the sinus node was. Granted, the sinus node is not a point, it is an area, it's a focus of cells, cluster of cells. So you can have some slight different morphologies of the sinus rhythm, but it looks like a different beat. So we'll call that a PAC, and because that doesn't conduct, and there's a couple that come in quick succession, so premature atrial contraction, and because it comes so quickly, the QRS isn't ready. It's taking a nap, it just fired like a few milliseconds back, it wants to wait till it goes again. So the AV is blocked. In this case, it's normal. So this is basically the ventricles or AV nodes refractory, not ready for an activation. So we call that a blocked PAC, and most cases this ends up being a benign finding. But if we saw, instead of this, a normal sinus beat that did not conduct, and the next PR is shorter, that would be, back to one of our previous cases, that would be Mobitz 1 AV block. We cannot call this that.
If you are interested in learning more about cardioneuroablations, Dr. Kalgi had a great conversation with
Dr. Kashu.
Dr. Kashu.
Yeah.
And if you're interested in learning more in detail of what that procedure involves, that's a great opportunity to look at that podcast as well. So if you're also interested in finding more learning resources, you can follow Dr. Kalgi on Instagram. And thank you once again for joining us today.